Welcome, everyone. Good morning. I'm Descartes Lee. I'm the Vice Chair for Education at the Department of Psychiatry and Behavioral Sciences, University of California, San Francisco. Just before we start, I want to remind everyone that there will be a Q&A session of approximately starting at approximately 9:25. And during this talk, if you have questions for Dr. Johnson, please submit them via the public chat box. Or if you'd like to ask a question live, which is also fun, please click on the reactions button and raise your hand, or just chat me and I'll give you a chance to, I'll call on you and give you a chance to ask your question live. The host will unmute you once you're called, or I will unmute you. So the topic today is emotion-related impulsivity. And one of the things I like about psychology nowadays is I think things are named after what they mean. So this is a good topic, right? So, I feel like and Dr. Johnson will correct me if I'm wrong during this talk, but I was thinking many individuals report, regretting things that they've said or done kind of like in the heat of the moment. And, we're certainly all aware of, individuals, or I am at least, who in the midst of like a mood episode, like mania, for example, who are prone to impulsive action. That's kind of almost a definition of mania, for example. But I'm also aware of individuals who kind of report impulsivity, particularly in relation to strong, acute emotional states. And I think to my mind, the questions are, is this a characteristic of people in general? Is this something that's a trait that we can understand in people? Is this a risk factor for other psychopathology? I kind of am curious about, is it heritable? But maybe even more important, like, is there anything we can do about it? That seems like a really key thing. So, our speaker today is a professor of psychology at the University of California, Berkeley. She's been funded by NARSAT, NIMH, National Science Foundation, and NCI. She's published over 275 manuscripts and published in, the American Psychologist, Psychological Bulletin, Current Directions in Psychological Science, and the American Journal of Psychiatry. Apparently, she's had, Googling this, she's had over 18,000 citations. She's a co-author and co-editor of 6 books. She's a fellow for the Association for Behavioral Medicine Research, the Association for Cognitive Behavioral Therapy, the Association for Psychological Science, the Center for Advanced Study of Behavioral Sciences, and the former president of the Society for Research in Psychopathology. Now, I think she's obviously very well published, but I would say that her work is focused on 2 main themes: reward sensitivity and emotion-related impulsivity. And so we're going to talk a little bit about, I think she's going to give us a talk on that. And she has developed a theory and measures regarding trait-like tendencies for emotion to trigger impulsive behavior, or also known as emotion-related impulsivity. She has shown that this emotion-related impulsivity is elevated across both internalizing and externalizing disorders. And within the mood disorders, it relates to functional impairment, suicidal ideation, self-harm, suicidal action, and aggression. She currently focuses on cognitive and neural mechanisms of this kind of impulsivity and on the treatment and on its treatment. And she is going to, I think, suggest to us that online interventions for this tendency can actually reduce self-harm and aggression. So again, please, everyone, join me in welcoming Dr. Sheri Johnson, and questions in the chat. Thank you. Take it away, Sheri.
Thank you so much, Descartes. That was really very kind. And I really want to say a huge thanks for having me back. I spoke to you folks a couple years ago. Many of you have been, real sources of support in this work, and I'm grateful to have the chance to have the dialogue with you. Yeah, so look, it's COVID. It's been COVID. It's been a year and a half for all of us. And we probably all had days where we said or did something in the heat of the moment that later we sort of thought, oh my gosh, I can't believe I did that. Just blurted out the emotions of the moment. And so I think this is something that we can probably universally understand. But imagine that you were the person who did that every day or a couple times a day. Those are the folks I'm really interested in, is the people who just chronically in a trait-like fashion have a really hard time regulating once they're in those emotion states, and they're saying and doing things that they really regret. So I'm going to hope to convince you that that has a lot of meaning for their lives, that we can understand a little bit about what it is, and that we might have some hopes for treatment approaches. But you tell me when we get to dialogue. where the gaps are in that. I don't have any conflicts to report. And I'm going to start with a little bit of definition. I'm going to focus on this kind of unusual idea that this kind of impulsivity is actually really relevant for mood disorders. Talk some about early findings with neurocognitive correlates, and then talk a little bit about some treatment development we've been doing. So kind of 4 themes here. Okay, so first thing I want to say is that everybody I know who really focuses in on impulsivity starts to hate the word. It's almost like we should ban the word from our language because it's not one thing. And the different facets of impulsivity are really only modestly correlated with each other. It seems to be a collection of things. And I am really only interested in a kind of very focused way on one part of this, which is the emotion-related impulsivity. So my work was really influenced by work that Whiteside and Lynam did 20 years ago, where they developed this upscale based on a huge factor analysis of items related to impulsivity. And they came up with this scheme that there were 4 different separable, statistically relatively modestly correlated forms of impulsivity. The one I'm particularly interested in is this urgency, which was the tendency to act rashly during states of mostly negative emotion. There is a lot of people who endorse this who don't report other kinds of impulsivity. So at baseline, without the bad moods, they're pretty well regulated, but put them in a bad mood and things start to happen. Now, along the way, 6 years later, Melissa Sider said, you know, clinically, there's also a group of people who show this when they're in a great mood. When they get excited, they make the mistakes. And she developed a positive urgency scale. So there's kind of good or bad moods can trigger this. And the items are pretty simple, although some people hate them because they're double-barreled. But when I get upset, I often act without thinking. When I feel rejected, I'll often say things I later regret. When I'm very happy, I tend to do things that may cause problems in my life. I tend to lose control when I'm in a great mood. So pretty straight ahead concepts. There are parent and interview-based versions. And this thing has taken off. There are now over 1,200 publications with this scale. I had a grad student who made it his goal every morning to kind of send me the latest findings with this. And I was like, cut it out. You're stressing me out. I can't keep up. I could spend my day reading what's popping out in this area. What I like is that both of these have been shown in lab and ecological momentary assessment studies to predict symptom worsening. So if you are high on negative urgency and we bring you in the lab and we put you in a bad mood by having you remember terrible things that have happened to you, you will be more likely to show symptomatic behavior. Given a chance to drink, you'll drink more. Given a chance to eat sweets, you'll eat more sweets. Same kind of thing with positive urgency. We bring you in the lab, put you in a great mood, and you're more likely to gamble and drink. So the scales work like they say. Once you put people in mood states, they look more symptomatic. And it's not just that some people are really critical of themselves because they have problems. Parent and informant report versions tend to predict psychopathology about as robustly as the ratings do. So there seems to be a there, not just a self-report bias. Some people immediately think, it just sounds like neuroticism. Yeah, just have a group of people who are more emotional. And so then, of course, they can't control it. It's correlated with neuroticism for sure. Negative urgency is, but those are pretty modest correlations. And in statistical models, you can control for neuroticism. And emotion-related impulsivity is still going to predict psychopathology above and beyond the role of neuroticism. And generally, the effects of emotion-related impulsivity on psychopathology are actually larger than the effects we see for neuroticism. So if it's so important, what the heck is it? So I think for more than 10 years now, I've been trying to figure that out, and I'll share some more about that. A lot of this work was with my recently deceased colleague, Chuck Carver. And we took this idea that if impulsivity reflects a failure of top-down control, then the question is, well, how broad is that? So we talk a lot about failures of control of impulses like behavior and speech during emotion, but does that also influence how well you can regulate your cognition and motivation during emotion if you have a failure of control? How broad is that top-down control failure? And to look at that, we gathered a large undergraduate sample and pulled together lots of measures of core constraint, wrote new items to try and capture, well, what happened for people's level of control over not just behavior, but motivation, cognition, to see if those things were related to each other. Let's see. So, what would lack of constraint over low motivation look like? You'd give up easily. You'd feel like you couldn't move when you got down. Sadness would paralyze you. Whoops. What about lack of constraint over emotion-related thoughts? Maybe in those moments, your thoughts would be much more extreme. Like when even one thing goes wrong, I begin to wonder if I can do well at anything at all. Kind of too much focus of the emotion getting embedded in the cognitive thoughts. As a control condition, we included some straight ahead impulsivity items that had nothing to do with emotion or didn't reference emotion. And we did a factor analysis and we got 3 factors. I'm going to start here. Factor 3 is kind of just the same as positive and negative urgency with a little bit of reflexive reaction feelings. It's the kind of when I get upset or when I get happy, I say or do things that I regret. Factor 1, though, is interesting. It's really about the failures of constraint over thought and motivation. When I get mostly sad, when I get upset, I can't kind of move. My thoughts get extremely negative. Everything kind of gets influenced by that mood state. So a very different kind of failure of constraint. And then factor 2 is our control comparison. It's non-emotion related impulsivity. Now, I've noted here that negative and positive urgency were on the same scale. And that's increasingly well recognized. There have now been 3 or 4 major factor analysis studies that say the good moods and the bad moods, impulsivity, they tend to be really, really correlated, form a higher order factor. And that's kind of why I prefer this word emotion-related impulsivity, because I think either kind of emotion is going to drive it. There's also some really interesting work. Descartes, you asked if this is heritable. It is about as heritable as any other personality traits. And interestingly, in a really recent analysis, the SNPs involved in positive and negative urgency, when they do a kind of SNP overall score, are highly correlated at a level of 0.74, suggesting that there really is something genetically in common about positive and negative urgency. So, what have I said so far? Emotion-related impulsivity, I think, is very distinct from other forms of impulsivity. It's present in people who don't have other kinds of problems with impulsivity. It's not about good or bad moods. It's triggered by positive and negative emotions. And if we looked at it from a framework of kind of dual process, top-down control, you see that there's 2 related forms of emotion-related impulsivity. And one has to do with not having very good control over your speech and behavior. The other has to do with not having very good control over your motivation and thought. And so I think it's really important to think about this being a broader phenomenon than just what's captured in the urgency scales. Okay, so why does it matter? Why talk to a group in psychiatry? Well, I want to talk to you about how important it is for psychopathology. We reviewed this in 2018 in the American Psychologist, but this is a meta-analysis that I really find striking, where Berg took articles involving the upscales and just calculated correlation coefficients. On average, negative urgency was about more than twice as related to psychopathology as were other forms of impulsivity, and it cuts across the board. It's related to lots of different forms of psychopathology and behavioral problems. When she did this, there was less available about positive urgency, but it was showing parallel levels of correlation. So both seemed really tied to psychopathology. It's not just cross-sectional. So this isn't just a phenomenon of, hey, I'm in the middle of depression or mania and I start to have impulsivity. The scores predict long-term onset and worsening of many different psychopathologies. And these are coming out of large-scale studies starting in middle school, tracing people for years. But what I was interested in is this kind of counterintuitive idea that impulsivity might actually be involved in depression if we're looking at this kind of impulsivity. We don't think of depression as being impulsive, but what about control over emotion? There were a couple of studies of just depressive symptom severity scales that said urgency was related to depressive symptom severity. I wondered if we could see this as linked to diagnoses of depression and whether it was comorbid or explained by comorbid conditions like alcohol or substance problems. There had been some really nice longitudinal large studies saying it predicted increases in depressive symptoms. So here we wanted to look at our broader definitions of emotion-related impulsivity using our new scale. And we used the scale to identify 34 people who met diagnostic criteria for major depressive disorder, gave them our 3-factor scale, and constructed models to look at the links of major depressive disorder with impulsivity, but controlling for alcohol use problems. And what we saw is that there were indeed elevations of both kinds of emotion-related impulsivity among people with lifetime depression. These are the beta scores. And that those largely persist, although they're diminished, even if you control for current symptoms. So when we're looking at fully remitted people, they're still saying, yeah, I have problems with both of these kinds of emotion-related impulsivity. We've replicated that in a second study with more people with lifetime major depressive disorder. This was Ruth Decker's thesis project. I'm not gonna dwell on that. And just this weekend, I found this article suggesting that there's, again, genetic overlap in the links between these forms of impulsivity with internalizing psychopathology. So there seems to be some shared heritability when they construct GWAS vulnerability scores and they correlate those for internalizing psychopathology, very positively genetically related to negative urgency and even moderately correlated with positive urgency. So something there seems to be linked. So one of the things, though, is, does this help us understand some of the more troubling outcomes that go along with depression? So sure, depression might involve troubles regulating those mood states. But there's something broader about constraint here because they also seem to be, it seems also to involve positive urgency. So this is one study that I think is really important where they followed over 1,000 women during their first year of college, and they found that urgency at baseline predicted the onset of self-harm behavior with pretty decent odds ratio, so more than 1.5 times as likely to engage in NSSI if you had higher urgency. And other forms of impulsivity weren't doing the trick in predicting onset. Didn't seem in this study to predict maintenance, and that's something we're continuing to study and try and understand, is that kind of disjuncture between onset and maintenance. We have some models of kind of where emotion comes into the picture there. Happy to talk about those more. Urgency also has been shown to relate to suicide attempt. This is a study following people from ages 10 through 25. And at every age group, suicide attempters show higher urgency scores than non-attempters. Now, we were interested in would our new scale give us any extra purchase on this problem? So we looked at that. And what we could see is that controlling for gender and depression and anxiety and every other form of impulsivity that we measured, it was our pervasive influence of feelings scale that was really the heavy hitter in understanding suicidal ideation. This is in a large group of adolescents who were all in residential care with high rates of suicidality. So this kind of, I can't control my motivation or my cognition was kind of more core to understanding ideation. And then not surprisingly, it's feelings trigger action that's about, I can't seem to control what I say and do, that was more correlated with whether or not people showed a suicide attempt. And this again controls for the psychiatric variables, impulsivity, but at this point, we're also controlling for ideation and plan. So this variable seems to help us think about who converts from ideation to attempt. I've also, as Descartes said, and this is why I've known Descartes for a long time, I've been really fascinated by bipolar disorder. And that's actually where I started to get intrigued by this concept, because if you've worked with people with mania, it feels like you've got emotion-related impulsivity in the room. They are doing and saying the things of the moment, guided by their emotion states. To look at this more carefully, we followed people. We wanted to really recruit a broad sample. So we recruited people regardless of their mood state, and we followed them for up to a year with monthly interviews to catch them during these well periods. And we waited until they had been well below kind of symptom severity levels in our interviews for at least 2 months. And then we wanted to assess how impulsive have you been in the last 2 months? Because we kind of know they're impulsive during this state. We wanted to know if this is more of a baseline characteristic. We also wanted to know if it's related to the anxiety and substance use that are really common in bipolar disorder. So we matched our bipolars to controls who had similar levels of anxiety disorders and substance use to make sure that whatever we were seeing was really a phenomenon of the bipolar disorder, not the comorbid conditions. So we gave them a heap of impulsivity measures, the Barrett, which is kind of the granddaddy, negative urgency, positive urgency, and a scale called fast fun seeking, and asked them, tell us what you've been like these last 2 months. Standardize the scores for comparison. And what you can see here is that our bipolars in green are reporting higher levels of almost every form of impulsivity, except for fast fun seeking. But they're particularly reporting that they struggle with higher levels of negative urgency. This was higher than these other scores. And they're particularly reporting that they struggle with positive urgency, that they tend to have a hard time regulating their behavior and speech when they're in a good mood. Not a mania, but a good mood during their well periods. So it appears that urgency and positive urgency are more elevated in bipolar disorder than other kinds of impulsivity are. And we've seen that in a couple other samples. Actually, we just saw it in a third sample of people at risk for mania. So they never had an episode, but they have like subsyndromal symptoms. Okay, so if it's elevated though, does it have meaning? Does it help us understand some of the troubling outcomes in bipolar disorder? So with Sarah Victor, we looked at functional outcomes in people with remitted bipolar 1 disorder. We wanted to know if this is part of how people get themselves in trouble and have more impairments in how their life is going, even during their well periods. We looked at quality of life. We looked at global assessment of functioning. And what we saw is that positive urgency was predictive of poor quality of life, poor global assessment of functioning in our remitted bipolars. And you could control for symptom severity, you could control for episode history, you could control for age of onset, you could control for other kinds of impulsivity. These effects are just kind of there above and beyond the other clinical characteristics. It seems like positive urgency is really kind of tightly bound to these outcomes. you could control for comorbidity too, if that wasn't explaining it. So, sorry, my computer's freezing a little. Okay, what about anger and aggression? And this, I have to say, always makes me nervous to talk about this. But I'm going to talk about it because I think it's a really important clinical issue. People with bipolar disorder have close to 5 times the risk of violent conviction of the general population when you look at the Dunedin epidemiological study. It's evidence that they're more than 5 times as likely to endorse that they've threatened somebody with a gun. And they're more than, I think they're 16 times as likely as other people to say they've had a physical fight in the past year. Now, to me, this feels like, boy, we have to tackle this because it's going to smash people's lives. It's going to smash their sense of self-esteem. And it's stigmatizing. And I always worry about talking about it because the last thing I want to do is stigmatize more. But as clinicians and clinical researchers, we've got to figure this out. We need to understand it and make a difference on this problem. Now, without a doubt, anger is a cardinal symptom of mania. So much of this is about mania being in the room. And for most people, after recovery, so give them good treatment, violence rates are within the normal range. But there's more variability in the bipolars than there are in other people. And so there are a group of people with bipolar disorder, not everybody, but a group that reports ongoing problems with anger and verbal aggression. And when they do, it's tied to kind of much worse life satisfaction and outcomes. So who are those folks and how do we understand and help them with this? Could this form of impulsivity help us understand it? And particularly post-remission. So we took 58 people diagnosed with bipolar I disorder. We followed them again with monthly symptom interviews until they've been remitted for 2 months. And we looked at their levels of anger after remission using a well-validated aggression questionnaire. And what we could see is that their levels of anger and aggression and physical aggression were significantly correlated, not just with negative urgency, but here I'm showing you positive urgency. And you might wonder why, because I think it's more telling that even difficulties controlling their responses to positive mood states are related to their aggression and anger problems after remission. Okay, well, what about the other most troubling outcome in bipolar disorder of suicidality? I don't have to remind you, I don't think, that 1/4 of people with bipolar disorder report a lifetime suicide attempt. And in any given year, half of them report suicidal ideation. And these are in the epidemiological studies worldwide. It's terrible. Like, this is no way for people to be. They are among the groups with the highest death rates from suicide. So in the Danish cohort study, 8% of men, 5% of women diagnosed with bipolar disorder died from suicide. And in other cohort studies in Northern Europe and in our own VA system, bipolar disorder was the psychiatric condition with the highest rate of death by suicide. So clearly a problem. And yet a puzzle. In using Barrett studies, we'd really seen no traction. Watkins and Meyer had published a really lovely meta-analysis saying there's really no significant effect of the Barrett impulsivity scores on suicidality. So here, what I wanted to do is ask, well, would emotion-related impulsivity give us traction in understanding suicidality within bipolar disorder? And it did. So we looked at both positive and negative urgency. We saw generally similar and significant correlations of urgency on suicidal ideation severity, number of self-harm attempts, like non-lethal self-harm attempts during their lifetime, and number of suicide attempts. The one place where negative urgency fared better was in helping us understand suicidal ideation. But generally, whether you had poor control over your good or bad mood responses, that was tied to a range of self-harm problems. So emotion-related impulsivity seems more closely tied to psychopathology than other facets of impulsivity are. The correlations are at or above the magnitude we see for neuroticism. And that's coming out of cross-sectional and longitudinal work. And it seems really relevant to mood disorders as well as externalizing conditions. So we see these effects in depression and self-harm and bipolar disorder and troubling outcomes within bipolar disorder. And it doesn't look like it's explained by things like alcohol or substance use disorder. It doesn't look like it's just a comorbidity or severity issue. And we get some traction by thinking about a broader way of conceptualizing emotion-related impulsivity. So if we take depression and suicidal ideation, those are more closely related to our factor of pervasive influence of feelings, which is kind of more about your core control over motivation and thought. In contrast, if we want to understand problems that are a little more behavioral, like mania, aggression, suicidal action, then the feelings trigger action score is giving us more of a larger effect size. Now, that's led to the hunt for what the heck is it, right? So what are the neurocognitive correlates? And to be sure, that's a hard task. Behavioral and self-report measures of impulsivity and of other kinds of phenomena tend to have pretty low correlations. It's hard to get a single point in time behavioral measure to correlate with a trait-like measure. But we're dogged about this. Okay, so these are all things that haven't worked. I'm just going to put that out there. There have been like hundreds of studies of looking for the neurocognitive correlate. It's like the elusive holy grail. These are all things that do not correlate, null effects. So moving from those, I want to kind of talk a little bit about some other model-based ideas. And the first is this idea that, well, maybe it's just emotionality. And then I'll cover these other domains. So what do we know about? Is it just somehow that they have more powerful emotions? Well, we did a study on this. We took 75 undergraduates who had a range of positive urgency, showed them, these are Berkeley undergraduates, so we showed them a Berkeley student winning the Olympic gold. We thought that, you know, it's a validated film clip for inducing positive emotions. And we looked at their subjective affect, their heart rate, their RSA, skin conductance. We coded their facial behavior. Nothing. Like, what a pack of null results for a hard study to do. Whenever I get null results, I'm nervous that I missed the boat somehow methodologically, but now there's a heap of these. Other people have been doing the same thing where they bring people in and they provoke mood states. They do standardized mood inductions. They give them speeches to do, cognitive failures. And no, these folks just do not look like they're having bigger emotion states. There's also now a bunch of fMRI studies. This is Matt Elliott, who helped me do a review in biological psychiatry. Generally, urgency and negative are just not showing kind of big profiles of reactivity to emotion inductions in the scanner. There are some spotty findings, but they are in slightly different places. These are some of the findings that are out there of maybe some difference in OFC. I'm going to come back to that because I think that this might be more of a regulatory phenomenon than a kind of initial reactivity phenomenon. Generally, though, we're not seeing amygdala, we're not seeing psychophys, we're not seeing subjective affect ratings be higher. I don't think that these folks generate a larger emotion response. I think instead something happens for a given emotion state that's different for them. So is it risky decision making? Well, we just did a meta-analysis of this. We actually got data from authors. We've got 144 effect sizes, and it's pretty darn modest. We have a correlation of 0.10. In other words, 3% of the variance between emotion-related impulsivity and risky decision-making. Generally, they're not gambling more. They're not failing on the Iowa gambling task. The only thing that's a kind of exciting signal here is that this effect goes much larger if you manipulate arousal. So after people were given yohimbine, which ups norepinephrine, then they started to show risky decision-making if they had higher urgency scores. So urgency was correlated more with risky decision-making during a condition that induced high arousal. That fits the scale, right? We say like you have problems when you're in a mood state. And most of these are just coldly looking at risky decision-making. So we see this as one kind of interesting signal, but it's one piece. Okay, for eons, people have said, well, impulsivity has really got to be a problem of executive function. And more than any facet of executive function, people have focused on response inhibition. So can you sort of suppress the urge to respond with a prepotent behavior or to a prepotent state? Why response inhibition? Well, it's kind of a core measure of can you constrain yourself? It's central in models of dual process and top-down control. And intriguingly, it rests on the very same circuitry as reappraisal does in the brain. The kind of cognitive control circuitry is what you use when you reappraise the stimulus. So we did a meta-analysis of those studies, and it looked pretty terrible in the student or community samples. These are our correlations down here. Pretty modest, a little higher than what we saw for risky decision-making. But then look at this, in clinical samples, there's signal there. What's up with that? Could it be that this is only involved when you have more serious problems with impulsivity and we're missing it down here? We thought, well, it also could be that nobody's kind of triggering mood states, right? So we think this is a problem that happens during mood states. Could we induce moods and then look at response inhibition? So we did 2 studies where we induced mood, then measured response inhibition using an anti-saccade task. So in one, we used a positive mood induction. In the second, we used a negative mood induction. And in both of those, after the mood induction, emotion-related impulsivity was related to poor response inhibition. So maybe it's mood state dependent. The other thing is that our effects were curvilinear, which kind of fits with that student versus clinical sample thing. So we only really saw response inhibition problems get markedly bad when we looked within our group at those with the highest impulsivity levels. At the modest level, there wasn't a whole lot there. So I think this is more of an explanation as you get into a clinical range. So let's talk a little bit about the neurobiology of this briefly. Response inhibition rests on the cognitive control network, which is activated during response inhibition tasks like the go, no go, the Stroop, the anti-saccade. It's also activated during emotion regulation. The extent to which you bring it online during emotion regulation will predict how much you're going to downregulate your amygdala in response to emotion kind of triggers. So it seems like a key region here. What do we see? Well, intriguingly enough, urgency does relate to differential and in fact, greater recruitment of the cognitive control network during a response inhibition task, only when that task, only during the conditions involving negative stimuli. So they seem to kind of have to almost work harder to engage this effective response inhibition when there are emotion stimuli present. So there is something anomalous about response inhibition neural processing for them. And that's been shown now in a few different studies. All 3 of those studies, though, involved emotion or reward manipulation. So it was only when you kind of got that kind of emotion state and activation going that they began to show these differences in their cognitive control circuitry. In the studies that didn't do that, in the one study that didn't do that, null effects. And in the conditions where people didn't do that, null effects. And so it seems like whatever's going on with response inhibition and cognitive control circuitry takes kind of having that push. So response inhibition seems implicated in both the behavioral and imaging studies. Its larger effects, though, in clinical samples may not really be an explanation for student samples. Bigger effects if you use positive or negative mood induction behaviorally or positive or negative stimuli in the scanner. And this idea that it has to be triggered, we also see in one single study of risky decision-making after a yohimbine administration, that's when you see a correlation of negative urgency with risky decision-making. So mood state dependent neurocognitive effects, basically. Now, what's a little weird is that you'd have neurocognitive effects during good moods and bad moods, right? Positive emotions and negative emotions. And that the one signal in risky decision-making is for yohimbine, which is really manipulating arousal levels. And so if you think about affect circumplex models, what might be happening is it's not so much about whether you're way down here or way up here. It might have a lot more to do with how active and aroused the emotion state is. So to look at that, well, to think about that, norepinephrine and arousal has been known for a long time to have a curvilinear effect on cognitive performance. I mean, that's why I drank a cup of coffee before this talk, is that a little bit of arousal tends to enhance cognitive performance. I didn't drink 6 cups of coffee before this talk because I would have fallen apart, right? Like there's an optimal level. We thought that optimal level might just be shifted downward for people with bipolar, not bipolar, for people with impulsivity, with emotion-related impulsivity. The idea being that it takes less arousal, for them to begin to fall apart and show declines in their cognitive performance. It turns out that pupil dilation is a really good peripheral proxy for norepinephrine. It's innervated by the locus coeruleus tract and corresponds very tightly to kind of subjective arousal levels. So we thought, well, we can use pupil dilation to look at what's happening with arousal for people with and without people with higher and lower levels of emotion-related impulsivity. And what we saw, so backing up, I should explain, what we did is we used pupil dilation trial by trial and did within subject correlations to say, okay, does your level of pupil dilation on a given trial tell us what to expect about your performance on the next trial? And for most of us, for the people with the lower feelings trigger action, a little bit of arousal, even the kinds of fluctuations in a very, frankly, boring lab task, was good news. It helped them do better. But as we got to the folks with the higher levels of emotion-related impulsivity, even a little bit of arousal was tied to a decline in how well they were doing. So for most of us, coffee, that little boost of arousal, great news for us, we're going to do better. For these folks, no, they're not going to do better, even with subtle shifts of arousal. They're showing these beginnings of kind of executive function response inhibition problems. We could show that with both scales of emotion-related impulsivity, and it wasn't there. That profile didn't fit for people with non-emotion-related impulsivity. So it seems like there's some specificity here that we would expect. Okay, so neurocognitively, our best guess right now is that there is something happening with response inhibition deficits that's consistent with what we see in the imaging findings of the cognitive control network. The findings are a lot more clear if impulsivity is severe, or if you push emotion or arousal or study the role of emotion or arousal. It doesn't seem like it's very much there or very strongly there if people are just in a neutral state. Single study also says risky decision making might get impaired if you pharmacologically manipulate arousal for people with emotion-related impulsivity. These are still small effects, though. I don't think it's the whole kit and caboodle. We're really working on enhancing our conceptual models, our measures. I can talk more about that afterwards if you're interested. But it's enough just to make me think, okay, we have two possible treatment targets. One is response inhibition and one is hyperarousal. Now with response inhibition, let's imagine for a minute that I can't use my cognitive control circuitry very well when I'm upset. Much of what we often do in cognitive behavioral treatment is we ask people to reappraise. Let's just try and think differently about this situation. Let's try and get some perspective. My theory is that's going to fall apart for them. That's just too cognitively complicated, and that we need simpler behavioral things that aren't going to depend as much on response inhibition. Now, to test this, we actually looked at it in a sample of highly aggressive people. Why? Well, aggression is a really clear behavioral target, and it turns out that aggression is very, very tightly correlated with emotion-related impulsivity across community and clinical samples. So we thought, all right, can we make that a bit of our target among our impulsive folks? We got Guggenheim funding to create an intervention for people who had both high emotion-related impulsivity and were showing aggressive behavior on a weekly basis. And our premise was quit using cognitive techniques that would rest on the heavy use of the PFC and cognitive control circuitry during moments of high arousal. So what did we do? It was so straight ahead that I felt like a radio psychologist. It's almost embarrassing, but we explained what emotion-related impulsivity was. We gave them feedback about it in their scores, had them talk to us about what it had meant in their life for a kind of motivational component. We had them self-monitoring using ecological momentary assessment to identify high arousal and triggers of high arousal. We taught them relaxation, which of course no one ever wants to practice, but then we said, okay, what do you do that helps you achieve this kind of calmer state? And can we help you plug that in? We used, again, phone reminders multiple times a day to say, okay, what kind of mood state are you in? If they were high arousal, remind them to practice their self-calming. And then we had them rate how well their coping strategies worked. We gave them personalized feedback after a couple weeks of everything we'd seen from those daily logs about, okay, when you were upset, when you were hyper, what are the things you tried, and how much of a reduction in your mood did it achieve? And then we said, let's choose the best one and have you pre-plan your coping around that. This is called implementation intentions, where it's like, okay, make a commitment to do one thing when you're upset. And let's really plan that out. So it's also simple that we did it online. So mostly web-based modules, but then we sent phone pings 4 times a day to kind of help really get this into their life, give them rehearsal, give them reminders. And this is the first article we published on it based on 212 people who had high emotion-related impulsivity and were engaged in aggression. 12% of our sample reported they'd had legal problems from their aggression, and they were reporting when we interviewed them using the Observer Aggression Scale, the OAS, 4.66 incidents of aggression in the past week. Our recruitment actually went viral, and we were flooded with people who were like, I need this. And when I started interviewing them myself, I was really struck how much of a need there is. These folks were doing some things that were kind of scary. What we saw is a drop off in aggression. The green is the Bus-Perry aggression questionnaire. The pink is our observer rated modified overt aggression scale. Both dropped significantly over the course of treatment, and we didn't see the same thing when people were in a kind of pre-treatment wait list. We really didn't see significant change there. So compared to wait list, we're seeing significant drop-offs from this kind of brief online intervention. Those are continuing or improving after treatment across a 3-month period. And within our protocol, we actually had 21 people with bipolar disorder sign up. We weren't recruiting for that, but they found us, signed up, and we saw similar magnitude of improvement in their aggression scores. Okay, so I've said a lot. I'm sorry to bombard you. You can tell I'm passionate about this area, trying to kind of figure it out. So what have I said? I think that the problems in constraint over positive and negative emotions are remarkably parallel, that positive and negative urgency deserve to be treated as a higher order factor, and that the real issue here is poor constraint. I think poor constraint is a broader phenomenon than we think about, that it's really correlated with, can you constrain how you think and what your motivation looks like in response to mood states. I think that these are really important, not across mood disorders. They're elevated, but they're also really related to key outcomes that we struggle with as clinicians in the mood disorders. The early evidence says something is involved with response inhibition, problems with response inhibition, but that's much more apparent in clinical samples. It's much more apparent if you have tested people during states of high arousal. And we've been testing interventions to enhance response inhibition, help people reduce high arousal, and come up with good strategies for coping with those high arousal states that aren't going to take a whole lot of cognitive control. So what are we doing from here? Well, we're in the year 6 and finally moving into looking at the cognitive neural mechanisms of this across internalizing and externalizing disorders, trying to test some more refined models of what we think the process might be. We also were surprised in our online intervention to see that not only did we have drop-offs in aggression, we also saw drop-offs in self-harm and suicidality. So we've developed new versions of our online intervention that focus on those outcomes. And with my former grad student, Andrew Peckham, who's up at McLean, we're going to be implementing those in day hospital settings to see if we can make a difference in the self-harm and suicidality dimensions. Along the way with this work, I want to give a shout out to some UCSF folks who have just really spent hours and time kind of thinking about this intervention work, and our newest colleague, Dimitri Young, who's helping us with some of the neurocognitive pieces. It takes kind of an army. These are complicated puzzles. And part of why I love being here is, look, I'm here in the Bay Area. I want ideas. I want to figure out ways to tackle this. I really welcome your collaboration and your ideas. There's already a lot of wonderful grad students and colleagues who've been helping with this, and I really want to give a huge shout out to them. And I want to open the floor for questions. This was a whirlwind tour, and I certainly welcome your thoughts. And Dr. Glowinski, I see your hand in the air. Bring it on. You're muted though.
Do you want to close your screen share, Sheri?
Yeah, thank you. Let's see people. Good to see familiar faces out there. Thank you all for being here.
I got a question if someone's struggling with their mic. Since I was the introducer, I think I feel like a first dib, so apologies here.
No, that's good. And Dr. Glowinski can maybe put hers in chat, but bring it on, Descartes. What do you want to know?
I was just kind of curious about, like, this is an area that's very new to me, and I'm not, I am aware of some literature on the effect of, it's very modest, the effect of lithium on neuroticism scores. Like, in general, we tend to think of traits as not something pharmacologically mediated, but it turns out that neuroticism scores actually it's modest, a very modest effect of lithium on that. But I would wonder about whether lithium would have a greater effect on, ERI, emotion-related impulsivity, and whether you could consider that. I'd be very curious about whether, because you do see in clinical practice, you put someone on lithium and they do say they feel like they're more modulated or they're less impulsive, even not in mood states, and would wonder if that would be protective of, prevention of mood episodes, full-blown mood episodes also. So that's just my
I totally love that idea. And I think we could probably gather some data even at the case report level. If you have people who are coming to you and starting lithium, it would be kind of amazing to look at that puzzle. The other, of course, pharmacological avenue that I think is fascinating is norepinephrine. But we just don't have good pharmacological data about this form of impulsivity, and it would be really, really exciting. So I'm going to buy you coffee and we're going to follow up on that.
Great. And okay.
Okay, so I think I can speak now, if that's okay.
Welcome.
Thank you so much. This was a really wonderful talk. You can imagine that in child psychiatry, we can't avoid but being really aware of emotional impulsivity, which we see indeed across several conditions. I think that what you talked about, however, the positive urgency is something that is more in the back of the mind of most clinicians and not necessarily considered well. And it's fun because I remember a documentary, 7 Up by Michael Apted. I don't know if you saw that movie. It's wonderful. The kid who was the most delightful at 7 ends up being the kid who has the most severe sort of breakdown in his functioning as he becomes an adult, which is obviously not a big sample, but I remember being struck by that years ago. And I think that part of what is not clear, and I'm interested in your thoughts, is that obviously longitudinally, we see kids who have sometimes this emotional impulsivity or lack of free want, in a sense. It doesn't necessarily track immediately. It's not comorbid at the same time with mood disorders, but obviously can be a marker. I would say it's definitely a risk factor. I don't know that we know the relationship of one to the other. So I think part of what's interesting is like, what can we do in childhood with this marker? And I wanted to know your thoughts about that as well.
Yeah, I mean, at a personal level, I think I've seen the phenomenon because I'm like my niece and nephew's favorite aunt, and their parents hate me being over there at night because I love getting them all wrapped up. And every parent knows, like, you don't do that in the evening. So there is a phenomenon there that I think is, pretty endemic in kids. What do we know? I mean, so certainly this continues to increase through adolescence, and then it declines through age 25, just like other forms of impulsivity as the kind of neural circuitry around cognitive control matures. And also it's interesting that it, spikes in adolescence when there's all kinds of, joy and peer kind of influences and sensation seeking sort of stuff going on. We know that it's predictive in childhood to some extent. By middle school, you can use these scores to predict kind of onset of problems in adolescence. But I think that the measurement is fuzzy in kids. We downloaded the ABCD data set, which they've just published some of the urgency data on. And we were really struck that almost all the correlations we would normally see with negative urgency and positive urgency in adults were sort of blunted in that kind of younger age sample. We're curious to see if those correlations look a little larger 2 years later, because I think there's just a lot of heterogeneity when it means what it means when you have a kid who's got that kind of big joy juice, can't constrain themselves sort of thing. I'm guessing parents do track it. Good parents do track it. Good parents think a lot about how to keep their kids kind of in the right zone and know where the kind of danger zone is. Oh no, you just got them too pepped up. And that those are skills that we can teach. Like, parents shouldn't have to invent that for themselves, right? And some parents are more insightful and adept about monitoring it and thinking like, okay, now we're going to do a little quiet activity, and other parents are not as good at that. So I think there are skills that could be taught.
I think, and that's super helpful. I think I'm thinking about the kids who are not like other kids who get excited because there's something exciting going on. Kids who go into the backyard at 4 and declare that it's just a wonderful, stupendous, beautiful day. That kind of time, I think, is more predictive of what we're talking about in terms of problem development. At least that is my clinical experience. So basically.
Yeah, totally. Sorry, I didn't mean to cut you off.
Oh, please go on.
I was going to say that that's the kind of insight we need to harness in thinking about how do we tune up these assessments in kids. Because what they've done right now is kind of taken the same questions and said, oh, ask the same questions of parents that you ask about 25-year-olds. And I don't think it's that sharp. And so I think it would be fascinating to talk to you more about, well, what would you ask a parent to get at that kind of extreme level of dysregulation? Because I think that we're missing some of the question sets and some of the coverage. And so that's brilliant. I hope you'll send me an email. I'd love to dialogue with you about it.
This is Descartes again, and I have to apologize, but it is 9:30, so I want to make sure that it's been the hours just whizzed by. So I just want to thank you and make sure everyone, and we already have a bunch of thanks in the chat here, and so just wanted to thank you. And can you stick around for a couple of minutes for more questions?
Yeah, I can.
I know I can. So, but I want to say goodbye to everyone else and just thank you so much. And it is being recorded, so if you want to catch the last few minutes and need to go, I think you can just jump ahead to the end there. So let's stay up for like 5 more minutes with Sheri, and thank you so much.
Thank you, Julio, for that comment. Good to see you. Right, and Keenan, good to see you. It's our new professor in psychology.
Yeah, he was just on and had his hand raised. Does he want to ask his question? Or?
Sure. Let's see.
Where is he?
I can't unmute either. Keenan, do you want to put it in chat?
If you raise your hand, I can unmute you, I think.
There we go.
Can we unmute him?
Yes, I can unmute. Thank you so much.
There we go. Okay.
Yeah, fantastic talk, Sheri. Just to the last question, and you were kind of hinting at this. I was just curious whether in that ABCD data set, does measurement and variance hold for younger kids versus adults? Kind of getting at, are these items actually appropriate for measuring this? Just have folks examined that development? Is it a mean level shift, or is it really that like these items just don't discriminate the kids? I just wondered whether you guys have looked into that.
Yeah, so we downloaded the data set. We wanted to look at functional connectivity, and we thought, well, before we do that, let's really probe that subscale, because it's also a short subscale. And to us, the reliability seemed more modest, the correlations with psychopathology seemed more modest, the correlations with other expected traits seemed more modest. And so we were prepared to write a paper sort of saying, this isn't really there yet. And we sent it to kind of the lead author of the scale to say, hey, we have these worries, would you work with us on it? And he's like, we just prepared an article that went out to Journal of Abnormal. And it came out in Journal of Abnormal, almost identical statistics with a really positive spin of like, look, it's, modestly reliable and it's modestly predicting these things. But so it's all in the eye of the viewer. But I just think like we could do better, because it's that predictive period that we really need to pick up on. So maybe you and I are going to have some fun discussions.
Absolutely. Looking forward to it. Thank you.
Great. Let's see. Is Lindsay still on? Lindsay Brewitt had a question. I think she may have left. She was curious about what types of aggressive actions were captured in the aggression treatment study in terms of participant report of their history.
Yeah, so actually we had a fair amount of physical aggression, we had verbal aggression, and it turns out there's a kind of literature of like at least 10 studies now of aggression and emotion-related impulsivity, and you can use the scale to predict lab-based aggression, you can, predict intimate partner violence, you can predict outbursts towards strangers, like it's kind of across the board. And I think one reason that this is a kind of decent outcome index when you're trying to think about poor constraint is if you think about responses to sadness, cultures really vary in what's okay to do with your sadness. There's almost no culture where it's great to kind of snap out at people or be physical aggressive. So it's a really almost pure measure. Did you have a failure of constraint?
Interesting. Okay, I think I'm going to make this the last question. Julio, are you able to unmute? Did you?
Hi, Julio.
It was more a comment, I think, from Julio. Is that correct, Julio? Just wanted to underline the importance of, emotion-related impulsivity and how we clinically assess patients at risk for suicide. And he thought it's really useful. Shake your head, Julio. Oh, I think you're unmuted now. Can you?
The card. Yes, I just wanted to underline that, thinking about my cases and my career, that I think that I would have gained a lot from actually conceptualizing about emotion impulsivity and emotion-related impulsivity when I try to assess and predict and prevent bad outcomes. So I think it should be elevated in our assessment of patients as a construct that you evaluate specifically, not just a diagnosis or whatever, but a construct that we use. So I wanted to support that.
Thank you.
And not just impulsivity in general also, but impulsivity during these high emotion points. Okay, I think we got to stop here. This has been awesome. We could go on forever, I'm sure. But,
Connie, on my website, you can find the standardized questions.
Excellent.
Cool.
Thank you so much.
All right. Thank you all.
Okay.
Great to see
Bye.
everyone. Bye.